we have Victoria Floriani, who will be presenting the New Jersey State experience with newborn screening.
Hello, everyone. My name is Victoria Floriani, and I am a research scientist with the New Jersey Department of Health Newborn Screening Lab. My role as a research scientist in the lab is to validate new disorders for our screening panel, as well as ensuring our current testing algorithms are working appropriately. It was my great honor to aid in the validation of XALD for the state of New Jersey. Today I'm going to share with you our journey to adding ALD to our screening panel as the 61st disorder. The addition of ALD to our screening panel was a long time in the making. So I'm going to try to peel back the curtain today to see the processes behind adding a disorder to a state screening panel. New Jersey law mandated us to begin screening for ALD in 2013. This law stated infants would be tested for ALD within 6 months following the following criteria: the occurrence of the development of a reliable test, the availability of quality assurance materials from the CDC, and the inclusion of the newborn screening and the inclusion of the disorder on the RUSP. By 2016, ALD was added to the RUSP, or the Recommended Uniform Screening Panel. After many long conversations with staff, researching a testing plan, consulting with other surrounding states on their screening algorithms, and deciding on designated lab space for screening, we were confident in our plan and the instrumentation that we needed to purchase. Procurement and funding were one of our biggest challenges, as the instrumentation required to screen for ALD is upwards of $500,000. These discussions began in 2018. The instrument was ordered in 2019 and was installed of March of 2020. We all know what happened then. Training was just getting ready to begin when the COVID-19 pandemic hit. Our state lab did not shut down. However, just like the rest of the world, working accommodations and priorities shifted. In 2021, it was decided that additional staff would be needed to validate ALD. The hiring process is just that, a process with any state. A position was posted in July of 2021, and by December of 2021, December 6th exactly, was when I started working with the state. And exactly 1 year later, we began screening for ALD. So how is New Jersey screening for ALD? We are using a 2-tiered approach for the screening of ALD. Our first tier uses the FDA-approved assay from Revity, known as NeoBase 2, using tandem mass spectrometry in positive ion mode. This assay is used to measure all amino acid and acyl carnitines on our testing panel. We were able to add C26, the very long-chained fatty acid which is elevated in patients with XALD, to our panel as it is included in the NeoBase 2 kit. However, the NeoBase 2 method detects an unknown interferent in the blood sample, which can cause false elevations in C26. Therefore, a second-tier test is required to eliminate these false positives. We developed and based our second-tier lab test with the help from a paper published by the CDC with Haynes and DeJesus. The second-tier test eliminates the unknown interferent by using an LC-MS-MS in negative ion mode. This method provides improved specificity due to the addition of the LC component, as well as running in negative ion mode. In order to add a new disorder to our screening panel, there are a series of tests that must be performed. First, we had to verify our existing first-tier Neobase-2 method, and then validate our new second-tier lab-developed test. For our Tier 1 assay, we had to verify the performance of Neobase-2 to detect C26. Tests such as reportable range, precision, and accuracy studies were performed following CLSI guidelines. Normal distribution studies were performed by testing 1,000 de-identified specimens. For our Tier 2 assay, a full validation was required, considering it is a laboratory-developed test. These tests also included precision, reportable range, accuracy, analytical sensitivity, and specificity. I will now take you through some of our findings from our verification of Tier 1, beginning with our normal range study. So what is a normal range? The normal range looks at the distribution of C26 levels in a healthy population. 1,000 blinded New Jersey newborn specimens were analyzed, and population statistics were consistent with those reported in the Neobase-2 package insert. Population statistics such as the mean, which was 0.26 micromolar, our 99th percentiles, and our 99.5th percentiles. Our next tests were precision and accuracy studies. I'm going to start with precision first. But what is precision? Precision data determines the assay imprecision and the instrument performance. Percent CV is a calculation that is used to look at the reproducibility of an assay. The lower the percent CV, the more precise the assay is. To test precision, we use 2 levels of quality control materials. Low controls and high controls were each tested 30 times. The precision was calculated to be within acceptable limits based on our acceptance criteria of percent CV plus or minus 20%. As illustrated here, we were within that 20% CV. Accuracy studies compare results to reference materials with known concentrations. 5 CDC proficiency testing specimens from the 2021 survey were tested, and we were in 100% concordance between our results and the original interpretation. Determining cutoffs were our next step, and they can be one of the biggest challenges when adding a new disorder to your screening panel. Collaborations with other states already screening for ALD were used to refine our screening algorithm, as well as analyzing samples from confirmed cases in our accuracy study. Due to the variability of the assay from the unknown isobaric interferent in the blood spot, we felt it was best to have the top 4% from every patient plate reflexed to Tier 2 for screening. In order to begin validation on our Tier 2 screening assay, there were supplies that were required to run and validate the assay. Unlike our Tier 1 assay, which is kit-based, the second tier is not. We first started with purchasing the instrument that would offer us the most specificity, and that instrument is the exact instrument that we use in the lab, and it's the Water Xevo XS LC-MS. Staff needed to be trained on how to use the instrument. Once trained, the instrument needed to be tuned or programmed to detect our analyte of interest. We had to purchase an internal standard specific to C26, as well as controls. Revity, formerly known as PerkinElmer, sold these materials that we purchased. Due to running the instrument in negative ion mode to eliminate that isobaric interferent, additional reagents such as ammonium acetate needed to be purchased as well. Once we had all the items required for our Tier 2 assay, we were able to begin our validation. Our Tier 2 validation began again by looking at the normal range, and the normal range looks at the distribution in a healthy population. The normal range study for Tier 2 screening revealed population statistics consistent with those from other states also running in negative ion mode. 1,000 blinded New Jersey newborn specimens were analyzed, and illustrated on this slide, we can see our patient median, which was 0.074, was very close to other states also screening for ALD. To test precision of the new assay, again, 30 replicates of low and high controls were run on the instrument. Results for precision were acceptable for C26 with a percent CV of less than 20%. For testing diagnostic accuracy, 43 samples in total were tested. Of those 43 samples, 5 were CDC proficiency samples. 38 of the 43 were blinded patient samples generously given to us from New York and Connecticut. Our results were in 100% concordance with their results. Our normal range study and accuracy data from the previous slides allowed us to determine our cutoffs for our Tier 2 screen. A C26 concentration of less than or equal to 0.16 micromolar is considered to be within acceptable limits. A C26 concentration of greater than or equal to 0.17 micromolar will fall into the borderline category. And a C26 level of greater than or equal to 0.27 micromolar falls into our presumptive positive patient category. After our verification and validation of our screening assay, a pilot study was performed, analyzing 3,000 blinded New Jersey newborn samples. And yes, I barcoded and punched every one of them myself. Our goal of our pilot study was to train staff, challenge our cutoffs, and have an idea of our referral rate in preparation of our go live. The mean concentration of C26 from Tier 1 was 0.44 micromolar, and the range was from 0.26 micromolar to 0.72 micromolar. Of the 3,000 samples screened using Tier 1, 108 samples were reflexed to Tier 2. The mean concentration of C26 was 0.079 micromolar, with a range of 0.042 micromolar to 0.156 micromolar. Following our pilot study, we were able to confirm our testing algorithm for our go live and estimated that our referrals to our follow-up team would be about 1 to 2 per month. Our current testing algorithm in New Jersey is as follows. All blood spot samples that arrive at the lab are screened for amino acids, acylcarnitines, and C26 on our first tier Neobase 2 assay. If the sample values for C26 are in the top 4% of the plate, our laboratory information system will automatically reflex those samples to be tested on Tier 2. The samples are then batched and run once per week. Each sample is punched in duplicate and run on the Tier 2 lab-developed assay. If the sample is within acceptable limits, no further action is required. If the sample is presumptive positive for ALD, we do not request a repeat sample on the baby. The positive result is reported to our follow-up group. If the sample is in our borderline category, we will request a repeat sample. Once the repeat sample is returned to the lab, that sample is again tested in duplicate. If the sample is borderline again, we consider it presumptive positive for ALD. This repeat borderline result is sent over to our follow-up team, who reports the results out. So what happens in New Jersey once a newborn is identified via screening? Borderline results for XALD are reported via the mailer sent from the lab with a request for a repeat filter specimen to be submitted. The follow-up team will call the primary care physician if there is no repeat filter on file within a week. They do this to verify that the primary care physician has received the result, and again, they recommend that they send a repeat filter to the lab. Repeat borderline and presumptive positive results are emailed to our follow-up team in a separate report as soon as our testing is completed. Results are reported to the family's primary care physician and also to the metabolic geneticist geographically closest to where the family lives. The geneticists in New Jersey have agreed to schedule appointments for these families within 5 days of receiving the abnormal results so that they can discuss this abnormal screen as well as collect specimens for diagnostic testing. If diagnostic testing indicates XALD, the families are referred to endocrinology and neurology for monitoring. We have 8 referral genetic centers in New Jersey for XALD. Since we started screening 15 months ago, I can't believe that it's already been that long, on December 5th, 2022, 123,505 babies have been screened for XALD. Of the 123,505, 6,288 have been reflexed to Tier 2. We have seen 3 female borderlines, 2 male borderlines, 2 female presumptives, and 6 male presumptives, giving us a total of 13 referrals to our geneticists so far. We have cleared 1 female via filter and 2 males. 1 male was cleared via genetics. Of the presumptives we have reported so far, we have 1 confirmed male with a pathogenic variant, 1 male with a variant of unknown significance, and 3 males that are still pending their genetic results. We have 2 confirmed cases and 3 pending, which would bring our rate of incidence anywhere from 1 in 24,000 to 1 in 61,500. And as we were on our way to the meeting here yesterday, the lab alerted us that we had another presumptive positive male that is the highest that we've seen so far. Illustrated on this slide, we have more detailed information about our 2 confirmed cases. Interestingly, one of our confirmed cases is a repeat borderline male with a pathogenic variant. On first-tier screening, the C26 concentration was 0.43 micromolar. This sample was reflexed to Tier 2, where the C26 value was 0.2, which falls into our borderline category. On the repeat sample, we had a C26 concentration of 0.18 micromolar, which is a repeat borderline and thus considered a presumptive. We had 1 male with a variant of unknown significance. On the first-tier screen, the C26 concentration was 0.77 micromolar. This sample was reflexed to Tier 2, where the C26 value was 0.33, which falls into our presumptive category. The long-term outcomes of these cases are not yet known, but these findings display the very importance of screening for X-linked adrenoleukodystrophy. Newborn screening really does take a village. We could never do this alone, and our validation would not have been possible without the support of several partners. Our neighboring state friends, such as Joe Orsini from New York and Adrian Manning from Connecticut, who provided us with those very precious patient-positive samples for our validation. Mary Karianopoulos for her technical consulting throughout our validation as well as priceless mentorship. And the constant support from our program manager, Miriam Schachter. And lastly, but certainly not least, Elisa and Miranda. ALD is where it is today because of your dedication, your outreach, and your work towards ensuring every state screens for ALD. And they are advocates not just for ALD, but newborn screening, period. They traveled to our state lab this past September. We celebrated Newborn Screening Awareness Month with a picnic, and we had a family presentation panel, and they very graciously attended that picnic with us, and we were so happy to have them there. I am truly honored to have had the privilege to speak before all of you today regarding New Jersey's experience, and I welcome any questions. Thank you.
I mean, I could ask you a lot of questions, but so your first tier, what's the workflow? Is that just done daily? Mm-hmm. And then your second tier, you said is done once a week?
Yes.
Awesome. And then your punching, how far in advance do you do that? Like
For first tier or second tier?
both?
First tier, it's punched immediately, so those samples are open, screened for quality, and they go right to the puncher. The mass spec plates are punched. Those mass spec plates are screened for amino acids, acyl carnitines, and C26 immediately. Okay. For tier 2, we do punch the samples a day in advance if possible. That's if we have the lab support staff to help us pull those kits and punch those samples. So we will punch them the day before, and they are run the next morning.
Okay. Thank you.
You're welcome.
We do have a Zoom question. What is the average age of the infant on the second newborn screen?
A week, 1 to 2 weeks.
Thank you.
Thank you guys so much.